DN is a 4-year-old African-American female who presents to the clinic appointment by her mother. The history was given by the mother, who is a reliable historian. The child appears well-nourished, well-developed, and is very well-versed. The family resides in a low-income apartment in West Shreveport. The child normally attends daycare but has not been in the past 2 days due to illness. The child has Medicaid insurance. She resides with her mother, who is unemployed, and her 9-year-old brother. English is the only language used in the home. The chief complaint voiced by the mother is that the child has been lying around coughing and running a fever for 2 days. The history of present illness includes fever, cough time 3 days, vomiting, lethargy, and headache for 2 days. The fever got as high as 102.9 degrees Fahrenheit on the previous night, and the mother has been treating the fever with Tylenol and Advil. The patient has had a dry cough and headache for 3 days and started running a fever and threw up once yesterday. She also has been sleeping most of the day and has had a very poor appetite for the past 2 days. She has been exposed to children in the daycare who tested positive for the flu. No one else in the home is currently ill. The patient is current on immunizations, has a past medical history of otitis media at 4 months of age, and upper respiratory infections, last one in February of 2017. She has no known food, drug, or environmental allergies and does not take any medications on a daily basis. She was medicated with Tylenol at approximately 5 a.m. this morning. The mother denies any pets, pet dander, dust, or other allergens presence in the home. There is no pertinent family history. In the reviewer system, the patient was developmentally appropriate. She denies muscle aches, weight loss, or night sweats, pruritus, rashes, lesions, admits to headaches, but denies dizziness, vision changes, hearing loss, or sinus pain. She denies ear, eye, or throat pain, denies ringing or fullness in ears, eye, ear, or nasal drainage, mouth lesions, bleeding gums, nosebleeds, nasal congestion, sneezing, or nosebleeds. Denies tooth pain or tooth caries. Denies chest pain, tightness, or heaviness. Denies wheezing or shortness of breath. Admits to coughing, which is worse at night. Denies diarrhea, constipation, with the last bowel movement being yesterday and it was normal. Admits to nausea and vomiting ×1 last night. Denies abdominal pain or tenderness, increased or decreased urine production, pain, hematuria, or odor with urination. Denies any bone pain or decreased range of motion. The mother also denies any coordination or balance issue, any developmental or psychiatric issues. She denies any seizures, numbness, weakness, or loss of consciousness. They do admit to headaches. On physical exam, the patient was well dressed, well kempt, and well nourished, alert, and oriented. She appears ill but is cooperative with the assessment. The vital signs are as follows: temp 101.9 degrees Fahrenheit, pulse 101, respirations 22. We were unable to obtain a blood pressure. The height is 106.68 centimeters and the weight is 20.46 kilograms. The BMI is 18.24. The head was normocephalic, atraumatic. The patient has very long, thick hair evenly distributed with no dandruff, mites, or lesion presence. The head and neck was within normal limits. The trachea was midline. The eyebrows and eyelashes evenly distributed. The eyelids are smooth. Vision was intact. No cervical lymphadenitis was noted. Conjunctiva was moist, pink. The sclera was white. The pupils were equal, round, reacted to light and accommodation. Extraocular movement was intact. The red reflex was present. No ocular exudate noted. The tympanic membrane was intact, pearly gray, translucent, with visible landmarks. Cerumen was noted in external auditory canal and the hearing was intact. The turbinates was reddened with clear drainage present. No lesions or edema were noted. The oral mucosa was pink and moist. The tonsils was red and intact, +1, with clear fluid present. There were no nodules or lesions in the oral cavity, no dental caries to teeth. The respirations were even, unlabored. The lung fields were clear throughout auscultation. There were no wheezes, stridor, or rhonchi. S1 and S2 was distinct. The PMI was at the 5th intercostal space of the left midclavicle line. There were no murmurs. The abdomen was soft, flat, non-tender with palpation. There were normal active bowel sounds present. No masses or hernias were noted. The skin was warm, dry, intact. The color was appropriate for ethnicity. No rashes, lesions, or breakdown was noted. Range of motion was intact bilaterally for upper and lower extremities. No deformities, crepitus, or tenderness noted. Capillary refill was less than 3 seconds, and the peripheral pulses was +2. The patient was awake, alert, and active. Appropriate mood and behavior was noted. She makes good eye contact with both practitioner and mother and answers questions appropriately. A rapid flu screening was ordered, and it was positive. Some of the stressors that the family were having were intrapersonal stressors. The physiological stressor was evidenced by fever, malaise, flu, and decreased appetite. For the interpersonal stressor, on the psychosocial, the mother was very concerned about the child. And so that was evidence of that. And as far as the extrapersonal stressor under the social cultural, the child attends daycare and she loves going to daycare and she gets along well with her peers there. And she's not able to go now that she's sick. So that was something that fell up under the social cultural stressor. Conceptual models, as stressed by Newman 2011, are used to help APNs provide holistic client care. They are based on the 5 patient variables, which was physiological, psychological, social cultural, developmental, and spiritual. Those are the 5 patient variables which affect the client's system, internal and external environment. Dee and her family are experiencing a negative stressor that has penetrated the flexible lines of defense. This is evidenced by fever, cough, and positive flu antigen. The flexible lines of defense protects the normal lines of defense. The mother has experience in taking care of a sick child because she has an older son already. She has been giving the daughter Tylenol for her fever. And so this is helping to control the normal line of defense and keep it strong. The lines of resistance have also been broken as evidenced by positive flu antigen and fever experienced by the child. There are 3 different diagnoses that were differential diagnoses that can be used for this case. One of them is influenza. The other one is pneumonia, and the third is bronchitis. With influenza, we have positive case data as abrupt onset fever, headache, anorexia, malaise, cough, abdominal pain, nausea, vomiting, tachycardia, and a positive rapid influenza test. The negative case data is myalgia, sore throat, nasal discharge, and chills. Pneumonia positive case data is cough, fever, vomiting, headache, anorexia, and malaise. And the negative case data is nasal congestion, wheezing, hoarseness, diarrhea, restlessness, dyspnea, and chills. For bronchitis, the positive case data is a cough, especially at night, postnasal drip, and an elevated temperature. The negative case data is a low-grade fever, substernal discomfort, bronchi, mucoid sputum production, dyspnea, bronchospasms, wheezing, and crackles. Both the positive and negative case data were a result of February 2017. That's where I received that information from. The definitive medical diagnosis based on these positive and negative case data is influenza. Interventions for this patient are as follows, and these were taken from Uphold and Graham 2013. Instruct the patient's mother to ensure that patient receives yearly influenza vaccines. This is a primary prevention, and this has to do direct clinical practice. Instruct patient to strictly adhere to medication regimen. This is a secondary prevention, and this is Hamrick's expert coaching and guidance. Instruct the patient to return to clinic if no improvement in symptoms in 48 to 72 hours. This is secondary prevention, and the Hamrick is direct clinical practice also. Instruct the patient to ensure patient receives adequate fluid. Instruct the parent to ensure patient receives adequate fluid and nutritional intake. This is a secondary prevention, and this is expert coaching and guidance. And the last one is to instruct the mother on disease process of influenza through information provided on the CDC website. And this is tertiary, and this is Hamrick's research. There's also some teaching that we want to give the patient. One is to take ibuprofen as directed for fever. Maximum dose is going to be 400 milligrams, and you do not exceed 4 doses within a 24-hour period. The ibuprofen dose is 200 milligrams PO every 6 hours for fever. That dosage was based on 5 to 10 milligrams per kilograms every 6 to 8 hours, and that was from Hippocrates. Take Tamiflu as directed until completed. Tamiflu is 45 milligrams PO BID for 5 days, and that's also from Hippocrates. Increase fluid intake. Cover mouth when coughing so as not to spread to the rest of the household. Practice good hand hygiene. That's also trying to keep everybody else in the house from getting it. Rest. Notify daycare of positive flu testing. She may return to school after 24 hours of being fever-free, and to return to the clinic for worsening of symptoms. If the symptoms have not improved in 48 hours or they continue to get worse, then she needs to return to the clinic, and also follow up in 7 to 10 days if the symptoms are improving but not gone. And that's from Uphold 2013. The client goals is that the patient will have activity level at pre-influenza state. And that's based on the nursing diagnosis of fatigue related to influenza virus as evidenced by increased sleep pattern. The second goal is increased nutritional intake to pre-influenza levels. And that's based on the nursing diagnosis of risk for imbalanced nutrition, less than body requirements as evidenced by decreased appetite for 2 days. And the third goal is that the patient will have no complications resulting from the influenza virus. And that's based on the nursing diagnosis of risk for infection as evidenced by 101.9 degree fever. The hypothesis is if the patient adheres to the medication regimen, the child will show improvement in 24 to 48 hours. If the patient and family practice good hand hygiene and avoid unnecessary contact, the sibling and mother will not contract the influenza. And the last one is the patient receives the influenza vaccine routinely. She will lessen her chance of getting the flu every year. My name is Wendy King, and this is the end of my presentation. Thank you.